Thank you all for the invitation. I want to start by asking the question, can medical storytelling save lives? To answer that question, I want to bring you all back with me to February of 2002 when I was a first-year medical student. In the mornings, I'd go to the anatomy lab and spend time with my cadaver. Then I'd head off to the medical school pool so I could swim laps and replace the stench of the cadaver's formaldehyde with the smell of chlorine, and then go off to the library to study. Medical students are tasked with understanding the human body in the form of test questions. That month, I was reading a book called Neuroanatomy Made Ridiculously Simple, and I was turning its content into flashcards. I'd write things like, which cranial nerve controls the tongue on one side of a flashcard and hypoglossal nerve on the other. By 9 p.m. on Thursday nights, I'd left the library. My roommate and I would go into the apartment next door where a bunch of med students would gather around our analog television and we'd watch the hit TV show ER. Now, unlike the vast majority of the millions of Americans watching the show, we were med students. And we were desperate to understand from those fictitious doctors what our lives would be like when we became real ones. The night the episode, A Simple Twist of Fate, aired, we could not at all relate yet to how badly Dr. Susan Lewis wanted to change her underpants after she worked through the night in the ER and then started another shift again the next morning. Those practical lessons would come much later. But when Anthony Edwards' beloved character, Dr. Mark Green, bit his tongue, and Dr. Susan Lewis went to examine it, he stuck it out and it went to the right. And Dr. Lewis said, no, stick it out straight. And he said, I did. And in that moment, we knew exactly what was wrong with Mark Green. Remember, we'd just been studying about the nerves that controlled the tongue. We knew which one wasn't working, and we knew why. His brain tumor's back, one of my classmates shouted. Totally, brain tumor. And we all high-fived each other because we'd gotten the answer right. We'd made the correct diagnosis roughly 3 minutes before the characters explained to the millions of other American TV viewers that his abnormal tongue movements suggested a recurrence of his brain cancer. Roughly 20 minutes later, Mark Green laid down in an MRI machine to end the episode, and America grieved a beloved character's devastating illness. But we were not grieving because we'd understood the science, we'd made the right diagnosis, we'd gotten the answer right, and in the process, we had lost the plot of the story. A man with a wife and 2 kids and a career that he loved would soon lose it all because of a terminal illness. The problem was that as we were learning to make medical diagnoses, we were losing the plot of our patients' stories. We were losing touch with the human side of medicine and with our own humanity. Back in college, I was studying both science and creative writing. In the morning, I'd go into these large science lecture halls where the professors, in an attempt to make the molecular and cellular pathways they were studying feel relevant, would flash photographs on the screen of patients with the various genetic diseases so we could understand their distinct facial features. In the evenings, I'd go into tiny seminar classes where we'd talk about the tools of creative writing, the importance of an opening line, the power of specificity, and the craft that goes into a great ending. As college went on, I embodied the interplay between science and creative writing. My science classes were understanding cause and effect. We were breaking down human beings into organs, cells, DNA, in preparation for my future study of diagnostics and disease treatments. In my creative writing classes, I was learning one form of human expression, and with the building blocks of language, I was learning how to make sense of the world that human beings lived in. By the time I applied to medical school, I told the admissions committee in my application essay that I had come to understand that the patients that I aspired to see in the hospital hallways one day were no different than the people I saw on the street or in the subway. Because at 21 years old, I had already understood that all of us, every one of us, would one day become a patient. The problem is that once I got to medical school, my skills in creative writing were not valued. Not once did I sit in the library and make a flashcard with Examples of empathic questions to ask a man with a brain tumor on one side and anything at all written on the other. Neuroanatomy was made ridiculously simple because it's predictable. It has specific patterns. There is nothing innately simple about acknowledging the humanity of a patient with a brain tumor. So by the time I sat down with my classmates to watch the episode A Simple Twist of Fate, I'd already forgotten to think of myself as a writer. Now, it should be simple for healthcare workers, doctors in particular, to maintain connection to our mission, to understand both the human side of medicine and exemplify our own humanity as we're taking care of patients. But unfortunately, it's not. Medical training is an apprenticeship. We are trained by those who come before us and those who are around us, and all of those people are very busy trying to find the correct diagnosis and do all of the work, so much work that is involved in getting our patients the treatment that is required. Medical communication is learned in part on the fly, ad hoc, as we are going through our day-to-day lives doing the work of diagnostics and treatment. My own introduction to clinical medicine also began as a first-year medical student. I'd walk out of the dorm and over to an actual ER, where I walked around with an actual ER doctor who was actually not Anthony Edwards, and we would look at actual patients. And I'd say things like, gosh, that guy's having a stroke. And he would say, no, Rachel, don't talk like a civilian. Say a 68-year-old man is having a cerebrovascular accident. When he was telling me not to talk to like a civilian, he was imploring me to learn medical jargon. Now, medical jargon is important. It allows for efficient, succinct, precise, and depersonalized communication between healthcare workers. Without medical jargon, hospitals, clinics, most of healthcare could not function correctly and safely. But medical jargon begins to corrode our thinking, and if we are not careful, we begin telling patients stories of their lives in a language that they do not understand. Now, I was fortunate that as I left New York City and traveled west for the rest of my training, first to become a pediatrician and then to become a neonatologist, I had formidable mentors who impressed upon me both how to become a strong and solid diagnostician and get the patients the treatment they required, but who also modeled and took the time to teach empathic communication skills. They impressed upon me that it was important to use the language of a civilian with the knowledge of a physician in order to make sure that patients absolutely understood what was going on with themselves and eventually their children. They taught me, don't say intraventricular hemorrhage, say stroke. Now, by the time I got to the middle of my career, I had embraced and tried very hard to model the lessons of my clinical mentors in pediatrics and neonatology. It was with this confidence that I came to work on a random weekday afternoon to take call for the night, and I found a particular baby who was very, very sick. I didn't shy away from her. I pulled up a chair beside her incubator, and while her medical problems were simple to name, her treatment was not simple. The nurse and I, along with many others in the unit that night, worked through abnormal vital signs, lab results, x-rays, each and every one a test question. And each and every time we got the answer right. But unfortunately, the baby died anyway, not because we'd made a mistake, but because death and dying are part of doctoring and we cannot always save everyone. Now, I have always approached the injustice of a child dying with a personal mission to give families my most dignified and compassionate self, because I don't want to be responsible for layering any type of miscommunication on top of such a terrible and tragic loss. So I sat down with this family and I offered them and presented them my best and most compassionate self. I thought carefully about my words. But unfortunately, this family's grief manifested as anger, and they blamed me for their child's loss. They twisted the meaning behind a single word that I'd said in kindness as proof that I didn't have a heart, and they stormed out of the hospital. I went home the next morning with the sound of this mother keening over her child's body at 3:30 in the morning echoing in my ears. and the pain that these parents had unleashed upon me in my heart. And I just couldn't see my way forward. I sat on the couch, my children were at school, my husband was at work, and I felt this wave of despair. And I did something I hadn't done in almost 20 years. I wrote about it. I wrote about not just that baby's death, but the act of witnessing children die as a physician whose job it was to endure these unjust and terrible and tragic losses while holding my own grief as a doctor and respecting and honoring the grief of parents who had lost their children. And when I was done writing, I looked up at my empty house and I felt better. Not because I'd fixed anything or diagnosed anything, but because I'd redefined meaning for myself and my work as a physician. And then I started to wonder, are there doctors that do this? Do other doctors write about their work? And I discovered a new jargon, narrative medicine. Rita Sharon, who founded the discipline of narrative medicine, defines it as the ability to appreciate, absorb, interpret, and act on the stories and plights of others. It is a specific form of catch-all phrases that you'll hear like health humanities or medical humanities, which are, broadly speaking, the overlap between healthcare and ancient forms of human expression, such as music, visual arts, and storytelling. I decided I needed to learn more about this, and I am, after all, a doctor, so I did what doctors do, and I went to a conference. I went to Dr. Rita Sharon's narrative medicine conference in New York City, and when I came out of the subway on Broadway and I walked a few blocks over into the same science building, coincidentally, where I'd sat pipetting yeast into petri dishes as an undergraduate student, I sat down in the large lecture hall and I was surrounded by the preeminent academic leaders in narrative medicine. And the pull I felt toward their work was so strong that it was like that room had discovered gravity and it existed nowhere else. I went home to Philadelphia and sought further mentorship and explored more and learned everything I could about narrative medicine. And eventually, I began to pull my residents out of my NICU into conference rooms, not to make neonatal anatomy ridiculously simple, but to have them read poetry. Now, at first, what I got were eye rolls and groans because poetry is in many ways the antithesis of medicine. It has no answer, let alone a right one. It is there to design a form of human expression, and everyone's impression of any one poem may be different and distinct. But I kept at it, and then again, because I am a doctor and doctors like to measure things, I asked my residents, first with a survey, and then with focus groups, what was I doing? What were they experiencing in these narrative medicine sessions at work? And they told me that they were learning empathy, that the act of talking about caregiving was in and of itself meaningful, that these conferences were instilling in them habits of compassionate communication and helping them remain connected to the human side of medicine. My own residents' experiences are not unique. If you look in the medical literature, there are many studies of healthcare workers and medical students participating in narrative medicine who say very similar things. It turns out that when patients participate in narrative medicine sessions, they also benefit. A meta-analysis by a Dr. Fioretti and her colleagues looking at the impact of narrative medicine for patients with diverse health conditions demonstrates that their health benefits when they engage in narrative medicine sessions. These sessions afford collaboration, reflection, and a measure of self-determination among many other learning modalities that are of benefit as we grapple with the universal experiences of sickness, illness, and human suffering as it pertains to healthcare. I started this conference by asking the question, can medical storytelling save lives? Stories, in and of themselves, can save lives. And hard stories, stories about things that make people uncomfortable, that are difficult to talk about, have a way of finding the people who need to hear them. The NICU is a place that is challenging to talk about in the public and collective consciousness because instead of the broad picture, which is that we are rescuing millions of babies who were fated to die at birth, people get distracted. They break it down into individual sick patients, parents who are struggling with grief and trauma and post-traumatic stress after childbirth, tubes, wires, surgeries, and they lose sight of the larger story. I took time to revise and publish the piece that I wrote after that one baby died, and it found its way, by the miracle of the internet, to bereaved families who'd lost their own children in NICUs and hospital settings, and several of them reached out to me because they were moved by my words as a doctor who had cared for children like theirs. Several mothers wrote to me and told me that the experience of seeing this reflected on the internet in an article saved their lives. I've gone on to publish many stories about my work as a NICU doctor, and every time other healthcare workers who share my experience and patients and families who have spent time in the NICU see themselves reflected in these stories that are otherwise isolating in our larger cultural collective consciousness. And because of this connection, the recognition, the respect and reverence with which I try to describe the NICU, they feel better. They write to me and tell me that in some measure my story has saved their lives. Now, medical stories bring us together. This is critically important at a time when Surgeon General Vivek Murthy tells us that we are living in an epidemic of loneliness. We are living in a culture that values immediacy and impulsivity and an illusion of immortality. And in the process, we have all lost the plot of the story. All of us, like Mark Green, are trying to twist fate and go on living one healthcare experience at a time. I wonder if we could reframe healthcare as tiny twists of fate. I ask you to consider your own healthcare story. Maybe instead of thinking about the diagnosis or the treatment or the words that were said to us or by us as the story, consider them as building blocks in a larger story of trying to survive, of the universal experience of being a patient. So I beg you to try it. Tell your own healthcare story to someone, or if you've told it, maybe tell it differently than you've told it before, and then ask yourself, how did telling this story save your own life? Thank you.